Okay. Good evening, all delegates. Welcome to today's Kenya Society of Anaesthesiologists hosted weekly webinar, kindly sponsored by Glenmark Middle East and Africa. My name is Angela Ongewe, and I will be your moderator for this session. As we jump right to it, I'd like to thank you for your time, all the participants, our sponsors, KSA, and definitely our speakers. We have excellent speakers lined up for you today. I would ask that as we go along the program, if you could keep your microphones off and post any questions or comments in the chat. And then I've dropped in the chat that if we have non-KSA delegates, and for the KSA delegates who are not using their full names, please drop a private chat to the host, Anaesthesia Kenya, with your name, your specialty, and email address for CPD tokens. And that way we can free up the open chat for questions and comments. And this makes it a bit easier to collate all the questions you're asking for the Q&A session later. I hope that will be fine. I hope everyone can hear me. Can the host confirm that they can hear me? I can see some feedback that no one can hear me.
Yes, we can hear you.
Thank you so much, Saurabh. Thank you. Thank you. So we'll jump right to it. Our first speaker today is pediatric intensivist of repute, Dr. Kaiser Fitzwanga. She's currently a part-time consultant at the MP Shah Hospital Pediatric Intensive Care Unit, as well as being involved in the aeromedical transport of critically ill patients with AMREF Flying Doctors Service. She's actively involved with our sister Critical Care Society of Kenya as an instructor in the basic assessment of intensive care. And this evening, she'll sort of be probing the question of whether we are trying hard enough in pediatric vascular access. Dr. Fitzwanga, the floor is yours. Karibu.
Thank you very much, Angela, and I'm very happy to be part of this meeting. I feel privileged to be sharing this talk on pediatric vascular access. And a lot of us, both in pediatrics and in other specialties, anesthetics, will agree with me that pediatric vascular access can be quite a pain. Yeah. I don't know if you can see my screen.
You can see your screen, Dr. Ari. We can see it.
Okay. All right. Okay. Perfect. Let's get down to this. All right. So I'm sure everyone has seen this. This is a very common scenario in hospitals where, you call Daktari Mtoto Hana line. And usually the people that get this call are either the anesthesiologist or an intensivist or any doctor who works in the critical care unit of any sort. So just as an overview, there are basically three types of vascular access. That's your arterial, venous, and intraosseous access. But for the purposes of this talk, I will concentrate on the venous and intraosseous access. And the indications can be elective, urgent, or emergency indications. And based on what the indication is, that's when you choose the type of access that you will use. So these are your common vascular accesses in children.
We can't hear you.
Oh, I'm sorry. So these are the common vascular accesses in children. Can you hear me now?
Sorry, we can hear you quite well. Maybe one of the participants, you can turn up your volume, but Dr. Ari, we can hear you. Thank you for that.
All right. Okay, thank you. So this is a picture that just shows the common vascular accesses that are utilized in children. And the blue ones are highlighting the peripheral venous access. For typically in children, we tend to use the dorsum of the hand, the dorsum of the foot, and sometimes the antecubital area. And then when things get really thick, then people utilize the scalp veins and occasionally the external jugular vein. The others, in terms of the arterial access commonly utilized in children, is the radial artery and the femoral artery. In neonatology, they tend to use the umbilical artery, and then the accesses that are highlighted in green show the common accesses for intraosseous access. We tend to use the femur most commonly in children. The tibia, both the proximal and distal tibia are common in children. Rarely do we utilize the femur and humerus in children. So this is a table that is just highlighting your indications for a central access. For a peripheral access, it's pretty much clear because we use peripheral vascular access for fluids and medication, commonly resuscitation fluids, intravenous fluids, and medication. But then now for the central access, it's very imperative that we know at what point do we need to order for a central access. So what normally do we use to aid in getting a peripheral vascular access? We very well aware that pediatric vascular access is very challenging. It's a painful procedure, brings a lot of stress to both the child and the parents. So having the parents present and not asking them to leave is very imperative. For the young ones, asking the mothers to continue breastfeeding, whether it is nutritive or non-nutritive, suckling and swaddling and rocking them. And then if you're to incorporate distraction techniques, then that should be appropriate for age, not inappropriate, because children also have their temperaments. And if you start using a technique that is not appropriate for the age, they actually get angry at you and more uncooperative. Some people in facilities where they're able to use local anesthetic, which is the common ones are a mixture of lignocaine and prilocaine mixture or tetracaine, can be used, and this has to be applied an hour before. It doesn't work instantly. You have to apply it an hour before and apply a cling film so that then you're able to get a proper pain management. And normally what we'll do is just apply a tourniquet, tap the vein, you may warm the skin, some people may use nitroglycerin. All these are attempts to cause vasodilatation. And others have used dextrose solution as a pain soother for children. So the headache that we tend to be faced in pediatric vascular access is that of this is difficult venous access, and studies have shown an incidence of up to 50%. And there's no consensus on what the definition of difficult vascular access, but this is a definition that I got from one of the studies where the investigators used it as a child who is a difficult access, intravenous access child, is one who requires more than 2 attempts at peripheral venous cannulation, and plus incorporating special interventions to achieve the intravenous access. That can be use of transillumination or infrared, near infrared light, or even ultrasound. So what are the features? Usually the commonest, it will be a history, a documented history that this is a child who gets difficult access attempts, and usually by the experienced clinician. In every hospital, there will always be that doctor and that one nurse who is known that difficult access, huyo akishindwa, that's a difficult access. Call anesthesiologist. That we all know. Others, it's parents who will report to you that my child has difficult veins. They always have to call an anesthesiologist to assist. Or your child, like the one in my first slide, very chubby, who doesn't have obvious visible or palpable veins. So it is imperative that we are able to anticipate those children who will be difficult access. And one of the tools that has been used is the DIVA score. And this is a tool that was developed by Yen in 2008, where it was done in the emergency department among nurses who do vascular access. And they looked at the success rate of peripheral venous access, and then looked at the factors that would lead to unsuccessful vascular access. And they highlighted visibility, palpability, and age as one of them. And then in 2011, Riker and colleagues now went ahead to now validate this score to actually use it as a predictor of difficult access. So as you can see, it's called a DIVA-4 score. It uses it's a cumulative of 10 and has the 4 parameters. That's your visibility of the vein, your palpability, your age, and history of prematurity. The use of skin shade was just an add-on, but any score that's above 4 is predictive of a child who will have difficult access. And this is the point at which, instead of struggling for hours, then you have to now start thinking of other means of getting access in these children. So many people have tried transillumination, near-infrared devices for difficult peripheral venous cannulation, but studies have not shown an impact in the overall failure. It will help in visibility, but in terms of your failure rate, there's no change in your failure rate. So what next? And I see that in Kenya, many people have embraced the use of ultrasound in vascular access, but for central access. However, there is evidence to show that ultrasound guidance can actually be also used in peripheral venous access. And there have been systematic reviews that have actually demonstrated that, you know, ultrasound-guided peripheral venous cannulation has reduced the number of cannulation attempts, the procedure time in both the emergency department and in the operating room. However, the caveat is, you know, for children who are awake, they tend to be uncooperative, difficult and struggling. So even experienced users in ultrasound-guided access will have a higher failure rate. However, for the anesthesiologist, for ultrasound-guided peripheral intravenous vascular placement under deep anesthesia and general anesthesia, deep sedation and general anesthesia, it has shown better outcomes. So it's more or less, it's a double-edged sword, I must say. So, sorry for that. This is just a video that's demonstrating peripheral venous access. Sorry for that. Okay. All right. Like my video is failing me, but it was a video that I just wanted to demonstrate. You know, the same technique that is used in central venous access is the same technique that is used also in peripheral venous access for ultrasound guidance. You just have to, one, you identify the vein, prepare, be comfortable, utilize the right size of probe. So for peripheral, for basically venous access, we tend to use the linear probes, the high frequency linear probes. Once you've identified the vein, it's imperative that before the procedure, you visualize the vein, and then now it's a clean procedure. You just clean the area that you're going to access. Seems to be failing me. Okay, I'll just move on to the next slide. Okay, so as I said, know your transducer probes. For vascular access, we tend to use the linear probe, which is a high frequency probe, frequencies of about 5 to 18 hertz for vascular access, and because they you visualize structures that are shallow. So this is a picture that's showing your approach to vascular access. So once you've identified the area, the site, you've cleaned it, then you put your probe, you visualize it before. So there are two types of views that we utilize. There's the short axis, which basically cuts across the vein. So you now, if you're depending on the type of probe, so this is the hockey stick probe. So you will center your vessel approximately at the center of the vessel, and that's where you will approach with your needle. So that would be your vessel. So you should be seeing, once you start pricking the skin, you should be seeing your needle coming through at the center of the screen. And then you may also use the long axis view, the in plane view, whereby length of the vessel. And one of the things when you're trying to identify whether it is a vein or an artery, of course, generally veins are compressible, so you will apply pressure. If it's compressible, it's a vein. You may want to apply a little bit of pressure distally to see as you employ a Doppler, color Doppler, and you see a venous blood flow towards you, which is depicted as red. So I just want to say, in ultrasound, red does not mean it's an artery or blue. Red just means it's blood flowing towards, and blue means blood flowing away. So when you apply pressure, then you see blood flowing towards your probe. So once you've applied it in the longitudinal plane, then you see your needle coming through the vessel wall and into the center of your vessel. And then now once a needle is in, you've advanced it, then you now remove the needle and advance your catheter. For ultrasound guided vascular access in peripheral veins, we tend to use longer catheters, because the standard catheters may be a little bit short and easily dislodged. So it is imperative that you just get catheters that have a longer length so that they sit inside your vessel. There's another technique that we call the dynamic needle tip procedure, whereby now positioning, whereby it's used to actually confirm that you're actually in the vessel. So as you visualize the vessel, so this is in the short axis view. Once your needle is in, you hold your needle still, and then you now move your probe proximally along the arm until you're unable to see the tip of the needle, and then you move it back, and then that tells you that you're actually sure and you're inside the vessel. This avoids you damaging or going through and through, because there's a tendency as you go deeper to go through and through the blood vessel. This was just another video that was demonstrating the views that I've talked about: the short axis, the long axis, and the dynamic tip positioning. Okay, I apologize for my technical hitches. Oh dear. Okay, let's get back to this. So one of the other, so we've discussed peripheral ultrasound guided peripheral venous access. One of the other accesses that is not very utilized in clinical care that people tend to shy away is interosseous access in pediatric use. And it's an old technique that was used in the 1930s for gaining vascular access. The beauty about this access is that the venous plexus is non-compressible. It remains patent even when you have poor circulation. So patients who are shocked, that access is patent. It's quite quick and easy to use, and it's been incorporated in pediatric life support. In fact, now American Heart Association, the European Resuscitation Council have adapted it, and in advanced pediatric life support, we actually teach it. It's one of the skills that you must get. So it's very quick, easy to perform, provides fast and rapid, reliable administration of fluids and drugs. And you can administer pretty much anything from fluids to blood products to antibiotics to your inotropes. And a lot of studies right from the 1940s have been done looking at the pharmacokinetic properties of infusates that you'd use using your interosseous access. And they've actually shown that there's no difference in terms of their pharmacokinetic properties. So it's actually something that everyone should be familiar with using and should not shy away. What are the indications? Pretty much very few. In a cardiac arrest situation, a patient who has no peripheral vascular access, just go for your intraosseous access, because within less than 2 minutes you have it. Patients who are critically, have critical hemodynamic instability and you can't establish a peripheral vascular access within 90 seconds, and patients who have acute hemorrhage. We should also be familiar of the contraindications, which are absolute and relative contraindications as we make the decision to use intraosseous access. The common sites for intraosseous access in pediatrics, we tend to use the tibia, both the proximal and distal tibia, but there are other sites like your distal femur and your proximal humerus that can be used. So these are the devices. There are several devices that can be used. This is the Cook needle. You have the bone injection gun, which is a spring, uses a spring mechanism to deliver the needle into your bone marrow canal. And then you have those who are fortunate to have the power-driven tool can use it. It's quite easy. And once you've gotten your landmarks, then it's quite easy to use this. And they usually come with, just like the power-driven gun for your intraosseous access, the needles are actually color-coded in terms of weight. So you just know which one to use. You have the Cook needle, which is also the same color-coded weight base for the different size. I just want to make a point that tools, you can actually use a hypodermic syringe, and in pediatrics we recommend a gauge 18 hypodermic needle for that. So you have this patient that meets the criteria for intraosseous access. You've identified that the indication, you want to rule out that they don't have any contraindication. Then you select your site. We use landmark techniques. For the proximal tibia, it's 2 centimeters below the tibial tuberosity and 1 centimeter medially. I hope my video will play, but that's something that we normally teach in advanced pediatric life support. And then you get your right side of needle. Always have your equipment ready, and because you have to clean the area. You then insert the needle, and once you get into the bone marrow canal and you aspirate, you may aspirate, you may not. That not aspirating from your intraosseous access doesn't mean that you're not in. The only thing is they should not be resistant when you're giving your infusions, and pretty much the blood samples that you can take can be used for most of the diagnostic tests. We try to avoid using for blood gas because if it has bone marrow fragments, then you're likely to damage your blood gas capillary tube. And then you can pretty much, as I said, utilize this intraosseous line for anything. Because of the low pressure in the medullary cavity, if you're running infusions, it's imperative that you use a pressure bag to run infusions. And in terms of how long the intraosseous line can stay, it's advisable once you've fluid resuscitated the child, look for alternative access, because the longer it stays, then the likelihood for complications. This is on a mannequin that is showing the insertion of an intraosseous access. You identify, I wish it could play, but it is what it is with my technology. Okay. Wait, I think I'll skip that. Okay, my apologies. It would have been lovely to just have a demo of how the intraosseous access is achieved, but it is a very simple procedure. So what are the considerations for the anesthesiologist in terms of intraosseous access? It can also be utilized in the OR, and if you have a patient who, is anticipated to be, difficult peripheral venous access, and in an emergency situation, it's advised, especially like a cardiac arrest or a patient who is, non-fasted, and you're not sure in terms of their volume status, consider the access. If it's not anticipated and a sort of semi-elective procedure, you may use other modes to achieve a peripheral venous access. But if you're unable and you urgently need to anesthetize this child, by all means, get your intraosseous access, and then now you can start looking for other alternatives. And theater being more of a controlled environment, then you can now go ahead and either do a central access or even just an ultrasound guided peripheral venous access if they don't meet the indications for central access. So what's my take home? Pediatric vascular access is challenging, and we should utilize the DIVA score more often so that we are able to predict those children that may need other alternatives to achieving peripheral vascular access. It's imperative that practitioners adopt routine utilization of ultrasound guidance for all types of vascular access. But I must say that the skill is a learning curve, and the more you do it, the better you become. Intraosseous access is a quick alternative vascular access, and it can be achieved quite easily and quickly in emergency situations or in a quad. And I would like to propose that hospitals should consider incorporating vascular access teams that are led by anesthesiologists or intensivists, and both, and just to improve vascular access and the care, and just reducing the vascular access related complications. Thank you very much. And my apologies for my technology failure.
Not at all, Dr. Fitzwanga. Thank you so much for honestly such a useful, relevant presentation. Thank you for your time. If there's a vascular access team, I'm not nominating myself for that. I want to now ask that the audience, the delegates, if you have questions, just post them in the chat, in the open chat, and drop your details for CPD tokens in a private chat to the Anaesthesia Kenya host. We'll hold questions for this to the end, and I'll now invite our sponsors and Glenmark. Their representative is Mr. Saurabh. Are you online?
Yeah, hi.
Okay. Evening. Good evening. The floor is yours.
Yeah, thank you. Thank you, doctor. My name is Saurabh Gadgil. I'm from Glenmark Pharmaceuticals. So first of all, I would like to thank the association for giving us an opportunity to present today and be a part of this particular webinar. So about Glenmark Pharmaceuticals, Glenmark Pharmaceuticals is touching lives of Kenyan patients since 30 years. And Glenmark has strong presence in Kenya in different therapies like gastroenterology, dermatology, gynecology, and respiratory. And we recently ventured into chronic segments like cardiology. Now, Glenmark is ranked among the top 75 pharma and biotech companies in the world and has operation over 80 countries. Glenmark has a strong research and development pipeline, and Glenmark always believes in innovation. Just to add on, Glenmark recently received approval of brand name FabiFlu for the treatment of mild to moderate COVID patients in India, and FabiFlu shows improvement of up to 88% in mild to moderate coronavirus cases. Thus, Glenmark is leading fight back against COVID. Apart from this, Glenmark also has initiated FATE trial, in which we are doing a clinical trial of cocktail drugs of favipiravir and umifenavir in India. The name of the trial is FATE, and soon the results also would be out. So this is a good breakthrough for us as a Glenmark Pharmaceuticals, especially during this COVID era. So for today, I would like to brief you on just one product, that is our enoxaparin. So before that, as I mentioned that, can everyone see my screen, Angela?
Yes, we can see your screen. Thank you.
So Glenmark, is in the new era, and we have got, as I mentioned, global presence of over 80 countries. We have more than 13,000 employees over the world. We are front-end in key markets. Even in Kenya, we are the #1 branded generic player. We believe in innovations. We have got 8 novel molecules. We have got 6 drug discoveries. We have niche therapy focused like oncology, hormones, and complex generics. We are among the top 75 pharmaceutical companies. We have 16 manufacturing facilities which are state of art, and we are present in branded as well as generic formulations. Now, for today, we have got LMW Enox, that is enoxaparin injection, which is available in 20 milligram, 40 milligram, 60 milligram, and 80 milligram. And we take this particular brand from the US FDA approved manufacturing site. And it can be used for prophylaxis of venous thromboembolic disease, treatment of DVT and pulmonary embolism, treatment of unstable angina, treatment of acute coronary syndrome, that is non-STEMI as well as STEMI. If you look into the mode of action of enoxaparin, it activates the antithrombin 3 and inhibits the factor 10 and 2, thereby prevents the clot formation. And it acts earlier in coagulation pathway, which has got high affinity to 83 and lower affinity to other proteins and cells. Therefore, there is a predictable dose response and less hemorrhagic side effects seen with enoxaparin. Apart from this, our LMW Enox can also be used. It gives a ray of hope in the recurrent pregnancy loss, in which 89% successful outcomes have been reported. It has got proven anti-inflammatory effects, and it modulates angiogenic pathways. In the trial of meta-analysis of 2,800 pregnancies treated with reported enoxaparin, it does not cross the placenta, less risk of maternal bleeding, less risk of neonatal bleeding, and no case of HIT, that is heparin-induced thrombocytopenia. Enoxaparin in pregnancy suggested therapeutic and prophylactic dose is 0.5 milligrams per kg for 24 hours. Therapeutic regimen is 1 milligram per kg after 12 hours. Again, for recurrent miscarriages, we have LMW Enox, which is present in 20 milligram, 40 milligram, 60 milligram, and 80 milligrams, which prevents formation of blood clots in the embryo as well as placenta, increases the production of cellular substances important to successful embryo implantation in uterine lining, increases insulin-like growth at the site of embryo's implantation, increases production of protein assisting in the binding the early embryo in the uterine lining, effect suppression of the immunologic cause of recurrent miscarriage. Again, if you see the prophylactic dose is 0.5 milligram per kg for 24 hours. Therapeutic regimen dose is 1 milligram per kg for 12 hours. So this was our product of focus today, that is LMW Enox. So thanks for giving us an opportunity. Along with this, I'm also having my colleagues, Mr. Boniface Gera, who is heading this particular division, and Emily. So the focus was today on this particular product. Thanks, Angela. Thank you.
Thank you very much, Sarab. Thank you. Thank you, Glenmark. Thank you again for hosting this, for supporting this learning session. We look forward to working with you, and supporting each other in the future. Thank you. We know you're staying online. So for the delegates, we are moving on to our second speaker. This is Dr. Lucy Mwaura. She is a locum consultant, cardiothoracic anesthesiologist at the Royal Papworth, Cambridge, in the United Kingdom. She has keen interest in cardiac and thoracic anesthesia, cardiac intensive care, advanced respiratory support, ECMO, and medical education. She has worked with us and partnered with us for quite a while, but she's been away. And today she'll be talking about really what's the evidence when it comes to opioid-free anesthesia. Dr. Mwaura, are you online?
Hi, Angela.
Hi.
Hi, yes, I'm online. I'm just working up to share my screen. Just
okay.
That's what I'm working up right now.
Okay, that's perfect. Dr. Mwaura is an anesthesiologist of many skills, many hidden talents. She's going to give us
Thank you, Angela.
quite some insights. I won't embarrass you here, but I'm really looking forward to your talk. Really looking forward to your talk.
So, okay.
Again, for our delegates, just remember you can keep posting your questions on the chat, the open forum, and post your details for CPD tokens privately to the Anaesthesia Kenya, that's the host. Karibu, Dr. Mwaura.
Okay. So hello, everyone. I hope you can see my screen and you can hear me all right?
Yes, ditto for both. Yes, we can.
All right, just a second here. So thank you very much, KSA and Angela and everyone for giving me this opportunity to give this talk. So I'm Dr. Mwaura, as she's introduced me. I work as a locum consultant in Papworth Hospital in Cambridge. So just... Sorry?
Sorry, we're just muting some people. If you can talk through them.
Right.
Sorry about that.
All right. So today I'll talk about opioid-free anesthesia. And basically, I'll just try and review the latest evidence as to the use of opioid anesthesia, opioid-free anesthesia versus against its use. So without further ado, I'll proceed. So begin. Okay. Sorry, I'm just trying to navigate my slides. Angela, I don't know if I still have full control over the slides or not.
You should. We're right here. Okay, good.
Oh, yeah, perfect. All right. So I'll begin at looking at a brief history of opioids. So we know that opium had been in use for many years before the discovery of morphine. But morphine was discovered in 1806 by a German pharmacist chemist called Frederick. And he discovered it from this plant called opium and named it morphine after the Greek god of dreams, Morpheus. So following this, in 1853, the hypodynamic needle was invented. And after it was invented, they began to use morphine to treat neuralgia. So later on in 1906, oxycodone was invented also by German chemist and pharmacist. And the reason they invented oxycodone is to try and maintain the analgesic potency of morphine while avoiding the tolerance and dependence that was associated with morphine. So that was just, and heroin too. So it was like an improvement in this. So later on in 1920, they were able to develop the synthetic opioids that we commonly use today, especially meperidine. Fentanyl was developed in 1950, and these drugs, as we all know, they are a big cornerstone and they play a big role in our management of anesthesia. So they are key as part of balanced anesthesia, so which includes analgesia, hypnosis, and muscle relaxation. And traditionally, most of the time, we cannot think about giving a good balanced anesthesia intra-op without having the opioids on board. So why then are they so beneficial? So they are able to maintain hemodynamic stability, especially for us who practice cardiac surgery. So in cardiac, we try to maintain a hemostable anesthetic. So opioids are very valuable to us. So we are able to give big doses of fentanyl to maintain this stability. So they are also strong analgesics, hence we commonly use them, and sedative. So that beneficial effect such that you have this very good painkiller, which will also sedate the patient, becomes honestly invaluable, especially in surgeries such as cardiac surgery. So why then should we start thinking of not using them intra-op? So the reasons include the adverse effects related to these opioids. We all know that opioids cause post-op nausea and vomiting, pruritus, urine retention, respiratory depression, where in some patients we might absolutely not want these adverse side effects, especially in patients with obstructive sleep apnea, patients undergoing bariatric surgery, patients undergoing thoracic surgery who might be having low FEV1, low vital capacity. So we want to try and make sure that these patients are breathing and moving as soon as possible after their surgery. So opioids are also associated with hyperalgesia intolerance. We know this for a fact, especially with the use of remifentanil. Sometimes opioid use intra-op begets opioid use post-op. So we end up just in a vicious cycle where we're using them to manage pain, but we end up using more and more opioids. So opioid-induced respiratory depression can be another problem where we can start thinking of reasons why we should use less opioids. Again, this is more relevant, especially for us who practice thoracic anesthesia. So opioids have also been linked with immunosuppression. So they've been seen to inhibit natural killer cells. So there've been links of them being associated with immunosuppression. So opioids have been investigated for as a causative agent for cancer recurrence, especially when used intra-op to treat patients with malignancies. But later on, there's no sufficient evidence to show that opioid use is associated with cancer recurrence. Then there's the big one, which happened especially in the developed world in North America, the opioid crisis. So potential opioid dependence and misuse with opioids use. So this challenged a lot the way we think about medicine and we think about how we manage our patients, especially in the perioperative period. So we imagine that most of the patients who end up developing opioid dependence later on, sometimes the first time they might have been exposed to an opioid might have been in hospital, maybe in the perioperative period. So if we think about it in that way, then we start thinking about reevaluating our opioid use. And finally, it might be that opioids some of them are expensive, especially remifentanil, and might even be unavailable. So this is a review article that I put up that was published in Perioperative Medicine. So it's about the rising tide of opioid use and abuse and the role of the anesthesiologist. So as I mentioned, it's just for us to reflect upon our opioid usage, because sometimes we are exposed to patients who are opioid naive, and the first time they're going to be exposed to opioids really is when we are giving them an anesthetic. So what exactly then is opioid-free anesthesia? We might already be doing it in our practice. I do know sometimes even in Kenya, I was giving opioid-free anesthesia, but didn't call it exactly that. But basically it's avoiding intraoperative opioid use. So we replace opioids with opioid-sparing drugs. So we end up either avoiding completely opioids or reducing their use to the post-operative period, where we just use less of them without compromising patient comfort. So we are giving less opioids, but at the same time, we want to make sure that our patient is still pain-free, comfortable, and without the adverse effects that are associated with opioid use. So one of the bases behind opioid-free anesthesia is a challenge to the fact that the autonomic or the sympathetic response that occurs during anesthesia is a reflection of pain. So this has been challenged, and it's basically a way to to try and avoid reflex anesthesia, where we're just giving opioids anytime the patient becomes hypertensive intra-op or tachycardic intra-op, whereas it might not necessarily reflect pain. So goals of opioid-free anesthesia, mainly we practice it to try and rationalize our perioperative opioid use. As I said, we are avoiding intra-op use of opioids. Then we limit the post-op use of opioids. Then another goal is to prevent persistent post-surgical pain. I know most of the pain specialists in this forum will agree with me, and we all know that poorly managed post-op pain can cause persistent post-surgical pain. So we want, despite the fact that we are trying to avoid the use of opioids, we still want to use other medications, other opioid-sparing drugs that will make sure that our patient is pain-free and comfortable within the perioperative period. Then another goal will be to enhance early recovery without compromising patient comfort. So we are hoping that by using less opioids, our patient is less drowsy in the post-op period, so early to be mobilized, less nausea and vomiting, and so patient is more comfortable and up and about. Then we want to also avoid opioid-related adverse effects that I talked about. I already mentioned tolerance and hyperalgesia. So who or which patients would benefit from opioid-free anesthesia? So this might be patients who have chronic pain, who are already on opioids. So you want to avoid giving more opioids. Then patients presenting for bariatric surgery, or bariatric patients or obese patients who have obstructive sleep apnea, or maybe pediatric patients with obstructive sleep apnea. Then thoracic surgery, as I already alluded to earlier, patients coming for day case surgery, or patients undergoing enhanced recovery pathways, because these are patients, again, you want a rapid turnover of patients. You want patients' pain managed well, patient is not having any nausea and vomiting post-op, and they are able to recover faster and get discharged faster. And then finally, the opioid naive patients. So basically, this is just a few of the patients who I thought would benefit from this mode, and who research has been done on opioid-free anesthesia. So then how do we do it? So the basis of opioid-free anesthesia is basically multimodal anesthesia, or multimodal analgesia as we know it and as we practice it. So local and regional techniques, they form a big cornerstone to this. We cannot do opioid-free anesthesia without local or regional techniques, because as we know, they have a key role in reducing the stress response that occurs during surgery. Then there's pharmacotherapy, again, multimodal analgesia as we know it, employing easy, simple, and commonly used analgesia, such as paracetamol, non-steroidal anti-inflammatory drugs. So all those things in combination. Then opioid-sparing drugs. So I'll take the next few minutes to just run through some of these opioid-sparing drugs. Some of them are drugs that we already use. Research has been done of them. We have been using them for a long time, but now they are forming the basis for opioid-free anesthesia. So these drugs are commonly, we've used ketamine for a long time. So ketamine is one of them. Alpha-2 receptor agonists. So clonidine, dexmedetomidine. I know most of you who work in ICU, you're quite familiar with those drugs. Then lignocaine, a lot of studies have been done on lignocaine, and we use it severally. Magnesium, gabapentin, NSAIDs, and dexamethasone. So on the right-hand side of the screen is just an image that came from the review article that I put up earlier, and it shows an old way like intra-op. So it's basically like a reflection of WHO pain ladder. Intra-op, instead of thinking fast, opioids, then paracetamol, then regional, but it's encouraging us the new way to think of the simple analgesic drugs first, then to move on to the opioid-sparing drugs, such as lignocaine and magnesium, ketamine, dexmedetomidine. Then if all else fails, then to move up to the opioids. So basically, it's just like the WHO ladder all over again. So just to mention briefly some of these drugs, I think we have time. So lignocaine, I think we were using it even when I was a resident in Aga Khan for the same purpose. So at a dose of 1.5 milligrams per kg, it's able to block the sympathetic response to laryngoscopy. So hence can be used instead of fentanyl. So we know that it's an amide local anesthetic. It has both analgesic, anti-inflammatory, and anti-hyperalgesic properties. So it's important for us to remember that it's metabolized in the liver, excreted in the kidneys. Hence, we want to avoid it in elderly patients and those with renal dysfunction. So there are some studies where they give lignocaine also as an infusion for opioid-free anesthesia. So in such situations, it's important for us to watch out for local anesthetic toxicity. So another drug commonly used for opioid-free anesthesia is magnesium. It's like an NMDA, also receptor antagonist. And it reduces the analgesic requirements and alters the duration and perception of pain when used. So normally we're using a bolus dose of 40 milligrams per kg. So it's important when using magnesium to remember that, especially when used as an infusion, it can cause delayed tendon reflexes and prolong the duration of action of neuromuscular blocking drugs. But it works very well, especially maintaining and managing hypertensive surges that occur during surgery. So there is this meta-analysis that's been published in Pain Medicine Journal that looked at perioperative systemic magnesium to minimize post-op pain. So basically they looked at, I think it was around 1,200 patients, and what they found that patients who received magnesium intra-op required less opioids post-op, and their pain relief was, their pain management also was lower pain scores post-op and required less opioids. So it had some form of opioid sparing effect in the post-op period. Oh, sorry. So I think I skipped the alpha-2 agonist. Then the alpha-2 agonist, clonidine and dexmedetomidine, as I mentioned, they are widely used in ICU to manage delirium and also for sedation. So they both have analgesia and sedative actions, and they have been found to improve the quality of analgesia and to aid opioid rotation in opioid-tolerant patients. They prevent and reduce the hyperalgesia associated with opioids. Important again for us to remember these drugs cause hypotension and bradycardia. So depending on the surgery and what we are using for, just to bear in mind, hypotension and bradycardia is common. Then ketamine, commonly used, widely used IV anesthetic, which has been there for a long time. So it has both analgesic, as we know, and sedative properties. So at a dose of 0.25 milligrams per kg, subanesthetic dose, it will provide effective analgesia and also have some opioid sparing effect. And hence it's very good for the opioid tolerant and opioid dependent patients. So again, the normal caution with ketamine, patients with increased ICP, ischemic heart disease, and hypertension, we need to be cautious about. Then finally, I'll just briefly mention the gabapentinoids. They have been in use for a long time, especially for neuropathic pain. And we know that they reduce the development of hyperalgesia and central sensitization. Their alphas are, they work on the calcium ion channels, and they're also very important in terms of when you're using opioid-free anesthesia. They've been investigated and patients are given in the pre-op period just before, like as a pre-med, gabapentin, pregabalin, doses of up to 600 or even 1,200 milligrams, and they've been found to work very well and have opioid sparing effects. So what is the benefit? So I just reflect a few studies to try and show the benefits that have been associated with opioid-free anesthesia. So there's this one study published in BJA on use of opioid-free anesthesia in patients who are undergoing bariatric surgery. So these patients got triple prophylaxis for post-op nausea and vomiting. They had two arms. So one arm got opioid-free Tiva that was given with propofol, ketamine, and dexmedetomidine infusion. And the other arm was given gas sevoflurane, and they got opioids. And they got, both groups got the triple prophylaxis for post-op nausea and vomiting. But the patients who had opioid-free anesthesia had significantly less post-op nausea and vomiting with comparable pain relief in the post-op period. Then the other one is about opioid-free anesthesia within an enhanced recovery for surgery pathway for minimally invasive lumbar spine surgery. So these patients underwent lumbar microdiscectomy. So they looked at the data retrospectively and examined the pain scores of patients who received opioids post-op and the ones who did not receive any opioids. Sorry, opioids intra-op and the ones who did not. So basically, this is just directly from that study. The opioid-based anesthesia had lower pain, they reported lower pain scores, but nothing was statistically significantly different. So basically the pain levels were similar. How much they required opioids, rescue opioids post-operatively was similar between these two groups. So the last review article I'll just look at is this one published just last year. It's the analgesic impact of intraoperative opioids versus opioid-free anesthesia. So this was done by researchers in Canada, and it's a systematic review of meta-analysis. Basically, they looked at all the studies that have been done comparing opioid-based versus opioid-free anesthesia and looked at the outcome of these patients. So what they found in summary is that 20% reduction in post-op nausea and vomiting among the patients who are having opioid-free anesthesia. No reduction in post-op pain level between the opioid-inclusive and the opioid-free group. And the length of stay in recovery, although it was only investigated by 6 trials, was similar between the two groups. No trials reported the hospital length of stay. So basically, the summary from this trial is that patients who did not receive opioids intra-op had less post-op nausea and vomiting, as we would expect, and the pain levels were not worse because they didn't get opioids in the intraoperative period, so it was just similar. So because I mainly currently I'm working in cardiac and thoracic. So what's in my experience in thoracic surgery, so again, I've reflected on an editorial there from some of the people here. So it's opioid-free anesthesia and the future of thoracic surgery. So I thought I'd share my experience, what we are doing here in Papworth. So for thoracic surgery, not all patients get opioid-free, but some specific patients, especially who we deem to be high risk of respiratory depression post-op, get opioid-free anesthesia. So the key thing is we do regional nerve blocks. So we do a paravertebral blocks, and this is mainly done for the VATS procedure. So it's minimally invasive surgical approach. The surgical approach to matters when talking about opioid-free anesthesia. So we give the paravertebral block before we begin, then induce the patient with propofol and lignocaine at the dose that I mentioned, then intra-op manage any pain with paracetamol, and we also give parecoxib just for pain management. We use magnesium to manage hypertensive surges that occur in the intraoperative period. Some people do use ketamine too, and clonidine is being used here. So that's my experience at the moment. So is it a one-size-fits-all for opioid-free anesthesia? Definitely not. Every patient is different. Every surgery is different. So we have to judge each situation as at its own when deciding whether we're going to use opioid-free anesthesia, especially if we're doing major surgery. We do know, and it has been demonstrated, that opioid-free anesthesia can be done safely even in major surgery, but we have to decide which patients will benefit from it and decide based on the surgical procedure, the surgical incision, whether it's minimally invasive or not. So it really does depend on the patient, and it's definitely not a one size fits all. So in conclusion, definitely more evidence is needed, more trials are required in opioid-free anesthesia. There is evidence, as I've demonstrated, for multimodal analgesia management plan. Opioid sparing can be done safely and effectively, as I've shown, and opioids can be reserved as rescue analgesia post-op. I'm sorry, I forgot to mention, when we do our thoracic VATS with opioid-free, we still do give rescue opioids in terms of PCA, morphine in the recovery area should the patient require opioids. So we still do use it as part of the multimodal pain management plan in the post-op period. So local and regional anesthesia techniques, they are key. They have a key role in opioid-free anesthesia. So it's very important for us to be doing our regional nerve blocks to be able to facilitate opioid-free anesthesia. So, and in summary, we just need to tailor anesthesia plan to the surgery and specific to the patient's needs. So basically that's it. Thank you very much for listening.
Hello? Okay. Thank you very much, Dr. Mwaura. Thank you. That had me, I have a bunch of questions myself. This was a very, very, very informative, very clear talk, very practical sessions we've had today. We're doing well on time. So we want to jump straight into the Q&A. Dr. Fitzwanga, are you online as well?
Yes, I am.
Okay, so I'll sort of jump between the two of you, give you some breathing space. So Dr. Nabulindo lauds you for a practical presentation of Dr. Fitzwanga, and she's asking, is training for vascular access part of the curriculum in teaching pediatrics in our country here? And how can we incorporate this as part of our curriculum?
Okay, thank you very much for that question. Unfortunately, I think where the training is involved is in peripheral, just the simple peripheral vascular access, which students learn as medical officers. And many tend to learn from colleagues, but I beg to differ if at all, because I don't teach at the University of Nairobi. I'm not sure that there's actually a dedicated training for simple access. So people learn from one another or from the medical officer. That's how they're trained. In terms of ultrasound vascular access, by the time I was training, we didn't have that. Central vascular access, during our ICU, I was fortunate that I worked in a private hospital ICU. So I got trained by my mentors, and that I worked with, and those who are in training taught me how to using landmark technique. In Kenyatta, during our ICU rotation, it was part of the training. I remember Dr. Misango used to tell registrars that you have to take ownership, learn how to do this, so that when you're faced with a need for central venous access, then you can do it instead of relying on the registrar who is covering the hospital. So I think we can do it a little better. And now that we have intensivists in pediatrics, I think we can throw in our weight a little more and train even pediatric registrars who come to do their rotations in ICU, teach them, empower them on central vascular access, empower them on ultrasound guided access. Yeah, I don't know if I've answered everything.
I think you have, Dr. Fitzwanga. Thank you, Kaiser. Thank you. Sorry, I would like to welcome our delegates from Botswana. I see people from Botswana, from Nigeria, South and West. Welcome for our webinar. Thank you for joining us. Lucy, this question will be for you.
Yes.
Dr. Lee Ngugi has a comment on chronic pain. So chronic pain patients on opioids, if his comment is that if opioid-free anesthesia is employed in this subset of patients, then opioid withdrawal would become a real risk that carries its own set of high morbidity. I just want to hear your sentiments. You're in agreement.
All right, so thank you for the question. Just my comment on that would be that definitely we need to continue giving these patients who are on chronic opioid use opioids, but if you're using opioid-free anesthesia, it's just in the intra-op period that you're going to withhold the IV morphine and then replace their usual maintenance dose. You continue giving it. So it doesn't mean that you completely withhold opioids from these patients. So it just means that intra-op, you're giving other interventions, and then post-op, you're continuing on to give them the opioids to prevent withdrawal. I don't know if that answers at all.
Okay, yes. To be fair enough, I'll just keep looking at the chat and see if Daktari is satisfied. That sounds good. Kaiser, so Dr. Lamglindo again, how often do we use pain-reducing techniques as we seek vascular access in our setup? And what do you imagine would be the challenge to this, and how could we improve on it? Sorry, I think your mic is off. Sorry. Okay, now you're back on now.
Yeah, thank you very much for that question, Dr. Nambulindo. Unfortunately, that's also a very pertinent and very important issue, because a lot of parents, that the source of their stress and anxiety, especially with multiple attempts, is the pain control, because the pain control causes more anxiety in these children. Unfortunately, during peripheral, the simple cannulation, we don't do a great job. Most often than not, you'll be like, tell the parent, please calm your child down, breastfeed the child, in a way, because we're also stressed. We want to get that access quickly, and even the way we do it and our facial expressions is even more disturbing to the child. However, when you're doing intraosseous access, you can actually infiltrate locally with lignocaine. We don't have that many places that has the topical preparations of lignocaine and prilocaine or tetracaine. So unfortunately, you end up just doing it without any sort of pain management. But the attempts that we make is basically telling the parents to breastfeed or distract with gadgets, and perhaps maybe even the way we are socialized to think that that Black people would tolerate more pain. That's my thinking, because I know in the white population you dare not put a simple cannula without applying a topical. So perhaps that's something maybe we can change and adopt and have it more available. And yeah, some places have used some vapocoolant sprays. I'm not sure about the efficacy of the pain control. Yeah, but if you're in the ICU and you're trying to establish access for a child, I think for the sicker children, then if this is a child who say was already on an infusion of an opiate or ketamine, then that may help with pain control. And of course, those who go to the theater, they may gas them down to, get some level of sedation so that, and then insert your access. Yeah, I hope I've answered your question, Dr. Nabulindo, but I must admit that we don't do a very good job in the pain management of children. We are establishing access, and I'd love to hear from our pain management specialists, how better can we do it? Maybe we also need as clinicians to be empowered. Perhaps maybe we don't know, maybe we need to be empowered. Thank you very much.
Thank you. Let me keep at it with you, Kaiser. Dr. Chokwe just makes a comment. Professor Chokwe says one should look at the structure of the IV cannula. Some failures are due to poor design of the access equipment. So here he gives examples of a blunt stylet or a significantly recessed retention catheter. I think you saw that comment.
Yes, I did.
Yes.
I do agree with him, because there are times when, you may get, like a change in what was ordered through procurement, and then you realize these cannulas, they frail so easily, and then that also it affects your success rates, because you may have visibly very visible veins and very palpable veins, but it's the quality of your IV catheters. I do agree.
Okay, thank you. So, Lucy, Dr. Misango was asking if you could make a comment on nefopam as an analgesic that may be used in opioid-free anesthesia. This would be, I guess, non-NARC, non-NSAID.
Sorry?
So nefopam, yes.
Is that like a non-steroid or anti-inflammatory?
I think it's a non-narcotic, non-NSAID. It's centrally acting.
Centrally acting. Oh, hello, Dr. Misango, wherever you are. Okay, so unfortunately, I don't have experience with that, but NSAIDs definitely are quite valuable in opioid-free anesthesia. So if it has opioid effect, then I don't think it's really opioid-free anesthesia if it's combination of an opioid and an NSAID. So I'd stick to an NSAID. Sorry, Dr. Misango, I don't have experience with that.
I don't have much experience either. I think it's no respiratory depression, I think from the literature, non-sedative, but I don't think, supraspinal, spinal pathways, but I don't think I would be in a position to give much comment on that either.
Dr. Misango will. So, Dr. Misango, I guess it would be good. It's anything that you're trying to do on an opioid that is working towards pain relief. So, I'd say.
Then still for you, Lucy, or I can see our chair of the society commenting that Papworth had the first heart transplant. I called him on the side to respectfully disagree and say that where I trained was the first heart transplant in UCT, but ours only survived 18 days. So Lucy, I guess you win that one again. Dr. Umani asks, if you've used PEC blocks, PEC 1 and 2, post-stenotomy for pain control in your cardiac surgical patients, what is your experience that for stenotomy?
Okay, so for this, thank you for the question. So for stenotomy patients, we have done a few PECs blocks, yes, but very, very few, to be honest with you, because the patients are normally kept sedated for some time, at least for 6 hours or so, 4 hours. And by the time we wake them up with a morphine infusion. So, and it seems to manage their pain well. We've not gone into great lengths to do opioid-free in cardiac surgery yet, as you can imagine, because we still do need the high doses of fentanyl for induction to maintain that hemodynamic stability. But PECs blocks, yes, we have done for pain management, but just in a few cases.
Let me speak on this vein with you. There's Farai thanking you for your presentation and asking about intra-op. The comment is that intra-op opioid-free anesthesia is reasonably achievable, but the challenge is managing post-op pain on the ward after. And the sentiment there that the good achieved in theatre seems to be lost on the ward, and what you would imagine would be achievable in a limited resource setting on the ward. That's Farai.
Yeah. So thanks, Farai, for the question, and thanks for that. So I think as I had started responding to you, maybe I just responded privately to you. So what I said is that if achievable, doing local regional techniques with a catheter, I know again that might be expensive to put the catheter in the local anesthetic infusion. Then I said also multimodal analgesia with simple analgesics, paracetamol, NSAIDs, all those are easy to use. So I don't know what else there are. So about low resource settings and
yeah, what would be reason? What would be? I suppose you've answered the question. What the options would be in a resource low setting where you can't run a catheter?
Really be, yes, just a catheter with a continuous infusion. That's the only thing that will sustain the patient in the post-op period. And simple analgesics, just multimodal as long as it's all of them. Paracetamol, NSAIDs, if you have gabapentin, all those would be valuable for the patients.
Okay. Thank you, Lucy. Kaiser, this one is for you from Larry Sisse. He comments that there's increasing evidence on guide wire, peripheral catheters, like midlines and PICC lines for DIVA patients. And do you have any thoughts on these two options?
Sorry. Thanks for the question. Yes, use of guide wires has been shown to improve your success rate in ultrasound guided peripheral vascular access. However, unless you're inserting, like say, your PICC lines, which are for intermediate use, like that child who say needs antibiotics and can only get, say, IV antibiotics, like a child who has a brain abscess that you want to give an antibiotic that will penetrate the blood-brain barrier, and you cannot give it orally. So instead of subjecting them to multiple vascular attempts, then that's the kind of child that you want to use your guide wire for access. But the other challenge is also if the vessels are small caliber, then you end up injuring the walls of the blood vessels. So in terms of my take, I'm very neutral about its use, except if I'm doing it for access that is for intermediate use, or even for, of course, your central venous access. You definitely have to use a guide wire. But then for the peripherals, I'm neutral about its use. Thank you.
Okay. That's thank you for that. Dr. Ziporang is asking, we have lost it. What do you think about a vascular access plan for children born prematurely who we expect to be in hospital for a long time and needing multiple vascular access?
That's actually a very pertinent question, and I think it's something that should be adopted in our practice. During my training in critical care, so the neonatal, we used to have neonates admitted for surgery, and straight away you just put a PICC line, because this is a child, like say a child who has a Fallot seal or a gastroschisis, that you anticipate that this child is going to be on parenteral nutrition, then you want to start when those veins are naive. And I think that's something that can be adopted back home. I think it's a brilliant idea. It reduces, the stress of the parents dealing with that premature child, because from the DIVA score, the prematurity increases your risk of difficult vascular access and actually failed attempts. So I think it's a good idea, and I'm sure my neonatology colleagues would agree with me. Peripheral inserted central venous catheters are actually very simple to insert, because you're inserting through a peripheral vein, and those complications like getting, if you're using your internal jugular or subclavian, you won't have those kind of complications because you're approaching through a peripheral vein. So I think that's a brilliant idea and a suggestion that we should incorporate perhaps, and just train people. And once people get used to it, then that it becomes part of institution, like an institutional protocol or principle. Thank you.
Okay, thank you for that. We're almost short of time, but I can just run through a few comments about EMLA being available in the country, and perhaps if we request for it to be more available, if we take an effort, then that would be something that we can easily do. Dr. Ngugi says that we have few doctors in Kenya, so maybe it might be better to have a nurse-led vascular access team, as done in countries in Europe, etc. Dr. Mwiti has a contribution with NEFOPAM for Lucy on her talk, and he says it can be and has been used for OFA, mentioned in literature, especially from Europe, continental Europe, and in his experience, he has experience with it and it works well, even for rescue analgesia. So he says it's given IV about 30 minutes infusion. Thank you, Dr. Mwiti, for that. So there might be comments still coming in, but we are due to close in 5 minutes. There's one hand up. Maybe our host, you can let Hamis Wazir will indulge you. Okay, I'll assume that that might be a hitch and not necessarily a question pending. So I think at this point, since we are winding up, I'd like to thank you, Dr. Fitzwanga and Dr. Mwaura. Thank you very much for your time. Thank you for your excellent presentations. They've been clear and concise, very informative, very relevant learning sessions. And we are absolutely honored to have had you take us through them. They generated lots of good questions, and I'm sure if the delegates still want to ask more questions, they can, if you will allow us to share your email addresses, and they can contact you privately, if that will be okay. Okay, we thank KSA for facilitating these regular sessions, and we thank Glenmark for sponsoring and partnering with us in this exchange of knowledge. We are looking forward to building bridges with you as we drive for safe anesthesia for all. To all of you, our esteemed delegates, thank you for tuning in from far and wide. Thank you for being faithful participants. We know it's not lost on us what a privilege it is for you to give us your time and join us in these sessions. And we invite you all to share your comments, your criticisms, your contributions, and your preferences for talks to come. Please join us next week, same time, same place, and have a good night, everybody.
All right.
Thank you. Thank you.
Thank you.